Hello.
Hello. So, welcome to everybody for the EUS Confluence Days 2021 virtual meeting. Sorry not to be with you really, but we will do that next year. And I just want to say hello to Pradam Shai and to Ankit. Okay? So, hope to see you very soon. Huh?
Yes.
Really?
Yeah, I hope so.
Really, yeah. Okay, I can remember very well the last meeting in Thailand. Huh? In Thailand, it was very nice, Pradam Shai.
Yeah, thanks for your trip coming to Thailand. We also very enjoy your trip at that
Okay.
time. We hope that we have a chance to welcome you again.
Okay. So, and Ankit, maybe one time in India, maybe next time.
Yes. Yes.
Okay,
absolutely.
so you are the moderator of the session too. So
Yes.
if you want to introduce the different presenters, so I let you the talk. Okay, so if you are the moderator, so now you can start.
Okay, all right. So welcome all the audience to session 2 of the EUS Conference Day 2021. In this session, we have 3 well-known and famous speakers on the 3 interesting topics. So I like to introduce the first topics. The first lecture is EUS-FNA versus EUS-FNB techniques and drawbacks by Professor Rajkumar Wadhwa, who is my friend. Professor Wadhwa is the current chief of gastroenterology and director at Institute of Gastro-Science, Apollo BGS Hospital, India. We have very good opportunity to hear Professor Wadhwa to have a talk in this topic. So Professor Wadhwa, please.
Thank you, Professor Padamcha. It's really nice to have you introduce me as a speaker. In fact, seeing you after a long time, it brings back a lot of memories behind. Hello?
Yes, we can hear you.
Yeah, yes, we can hear you.
Yeah. I'm just about to share my screen and then I'll...
Yes, you need to share your screen.
Yes.
Because actually we are only sharing your face.
Yeah.
We know that you are handsome, but anyway, we want to see your slides.
Thank you for that comment. But I certainly can't beat you. I think it's taking some time. Although the speed here, bandwidth speed is quite good.
Yeah. You go to the arrow button, the upward arrow
It has
button.
not yet come actually.
Yeah.
I'll come back again and try once again.
Okay. So FNA and FNB is it's one of the most common EUS procedure at this time, and both procedure have much difference between FNA and FNB, benefit on both sides and disadvantage on both sides, and so many techniques that been used for FNA versus FNB.
Can we see the slides now?
Yeah. Very good.
Okay, fine.
You succeeded.
Thank you for holding the fort for me, Dr. Pradam Chai. As he said, EUS-FNA and FNB are the area where we are looking to expand and get the best of the tissue outcomes when we start doing an echo endoscope. So we will first see what is the difference between the FNA and the FNB. Here is FNA works at the cellular level. We basically get to see the cells and the cytological analysis of it, while FNB differs structurally to give us a histological analysis. That is, there is a group of cells which are giving their original architecture as in the cells. And this is the fundamental difference between FNA and FNB. And hence, we have to have the idea of both the procedures, techniques, and what are the drawbacks currently available. FNA was first described by Peter Willman in 1992, and it has become the commonest intervention performed through echoendoscope. It has replaced CT scans and other interventions in certain areas where it has made the life easy for all the clinicians to get the accurate staging of malignancies, diagnosis of benign disorders to plan the optimum therapy. However, it is still not completely 100% sensitive and specific. Diagnostic accuracy ranges between 80 to 90%, and there are several limitations which we will discuss in the next few slides. Before we go on to the limitations, I would just go back to the basic techniques where patient preparation for FNA is similar to apogea endoscopy. Medications, you don't need to stop aspirin or non-steroidal anti-inflammatory drugs, and antibiotic prophylaxis is not required in majority of solid lesions. Side effects are minimal, mainly pain, rarely bleeding, infection, pancreatitis, and a risk of tumor seeding. And the risk in this situation is if you have a pre-procedure pain, or those, if we are doing it in malignancy, you tend to have a slightly higher chance of having a side effects. The basic technique involves a puncturing of a lesion which is identified. Now we have to keep in mind that lesion should represent the highest stage if we are puncturing the malignancy. And after the stylet removal, we make a to and fro needle movement. But before that, we make sure that there are no blood vessels inside. These tissue can not, this needle can be attached to suction based on our preferences, and then tissue can be sucked out. Once the tissue is taken out, air is flown through the needle and the tissue is spread on the slide. This, with gentle manipulation, can form a slide which can be observed to give us a completeness of the cytological analysis based on the appearance, macroscopic appearance. We also call it as MOS, whether it is complete or not. These slides can either be dried in air and stained with Diffquick to get a ROSE or rapid on-site evaluation, or it can be dried with alcohol and then sent to the lab for final analysis. We will discuss some of these as we go through discussing this basic technique. How does this tissue acquisition is affected upon? Of course, endoscopic training and experience is important, but there are certain other factors which alter the outcomes in this, and a lot of this is dependent on how we do, what equipment we use, when we use them, and what type of lesion we are doing it, whether it's solid, whether it is cystic, whether it is malignant, non-malignant, what type of needle we are using it, whether it is aspiration or biopsy, what gauge of needle we are using it. And are we using a different fanning different techniques like wet suction, dry suction, or any other such things. How we process this tissue also gives us the outcome of the tissue. So we will go on to looking into differences between the FNA and FNB while looking at these factors. So let us start with needle size. There are three commonly available needle sizes: 19 gauge, 22 gauge, and 25 gauge. When we do an FNA, there is high overall diagnostic rate. And if we think bigger the better, then probably it's not right. Earlier, it was believed that 25 gauge sample tended to be less bloody and hence gave a better diagnostic accuracy, but recent meta-analysis have shown that 22 gauge and 25 gauge gives almost the same diagnostic accuracy. Only thing, if we attach a suction, then the field can be bloody in these circumstances. So choice of 22 and 25G needle depends on the site in which we are doing a biopsy. 25G needle is more flexible and hence more useful where a curve is there, like in second part of the duodenum, while 22 gauge needle performs very well when there is a straight tissue obtaining, like in mediastinum or in stomach. 19G needle has been technically challenging. It does not give an improved result as compared to 22G needles, and it is mainly used to gain therapeutic EUS. However, there are certain areas where 19G has started to function well, and the most important of them is obtaining a liver biopsy specimen where we can get an adequate portal tracts when we use a 19 gauge needle in this. So should we move from A to B, that is from FNA to FNB, and why? FNA actually performed very well when we did this in lymph nodes and extraluminal masses. But when we looked it into the GI wall lesion, the diagnostic accuracy dropped dramatically. Apart from that, in other areas also, there has been a limitation of FNA needles, that there has been a false negatives to the tune of 10 to 25% in different setups, and much higher in pancreatic cystic lesions. It also never gives us the tissue for the analysis of special stains or in certain areas where tissue architecture is required. For example, taking a biopsy or lymph node for analysis of lymphoma, autoimmune pancreatitis or neuroendocrine tumor, where we require a preserved tissue architecture. And hence, probably biopsy needle works better in these circumstances. We look into this. So what are these biopsy? What are these needles? We probably can divide these needles into FNA needles and FNB needles. FNB needles initially, which first came to obtain a histological core, was from Wilson Cook, which gave us a quick core needle, and subsequently a reverse bevel pro core needle, where maximum experience is available. However, when the tip design changed, that is, it became a crown cut needles, the game changed, the analysis changed, the outcome changed. There are 2 or 3 different types of needles. We have Francine type of needle like Acquire, or the double bevel needles like Shark Core and Top Gain. Do these second generation FNB needle differ from FNA needle? There was a meta-analysis done comparing Procore and standard 5 needle aspiration, which told us that FNA needle and FNB needle gave almost a similar diagnostic accuracy and sample adequacy. However, FNB needle required fewer passes to establish the diagnosis. The biggest drawback of this meta-analysis was subgroup analysis was lacking. That is, we didn't know whether the pancreatic tissue performed the same or whether in the cystic lesion it performed the same. Recently, in 2019, a large meta-analysis which compared different needles, sizes, as well as compared the FNA and FNB needle was used. 2,711 patients with 11 studies, randomized control studies, where they determined that 22G and 25G needles performed equally well. They also failed to show the difference between FNA and FNB needles for diagnostic accuracy, sample adequacy, or histologic procurement rate. That means we believe that there was no difference between FNA or FNB when we look at this study. However, this study had several limitations and probably cannot be considered as representative because there was a lack of inclusion of different procedural techniques, whether the suction was used, what type of suction was used, and that could have made the outcome difference. Majority of the trials included in study included a reverse bevel tip FNB needle, which fails to demonstrate the superiority of FNA over FNB needle, as we have seen in the previous meta-analysis. However, only trial using Francine type of needle demonstrates different outcomes. Here, both the histological core as well as the FNA cell block had a significantly higher success rates to the tune of 90 to 95%, thereby obviating the need for growth. How does crown cut needle or the needle work is something like this, that the basic difference which has come is in the design of the tip of the needle. They puncture and cut through the core, and the core can be extracted out. When we look at the different types of crown cut needle, whether it's fork tip needle or whether it's Francine needle, difference in the outcome has not been much. Both these needles performed superior to FNA in sample and adequacy, both in pancreatic and non-pancreatic and intramural masses. When we compared procore needle with shark core needle for sample of histological analysis, shark core or acquired type of needle performed significantly superior to procore needle. Not many studies are available to find actual size of the core tissue obtained, but one study which tells us there was a significantly higher size of the core tissue obtained, thereby giving a better chances of special stains or the molecular analysis in these circumstances. Now, these were the areas where we could acquire. Are there any different techniques to improve the tissue acquisition? And we will go step by step in this. When we do a basic FNA or FNB, should we apply suction to it or not? What kind of suction should we apply? 5 ml, 10 ml or 20 ml? Nothing has been standardized and it is unclear whether the suction helps or not. It has become primarily an individual's choice, but generally it is believed that suction increases the field of bloodiness, and if we are using it with rose, then the outcomes are subpar or suboptimal when suction is used. Use of stylet, it is recommended by most of experts. However, randomized controlled trials have not demonstrated any significant benefit for use of stylet. People use stylet to push the tissue out, which might have come in during the puncture through the walls while reaching the target tissue. The most important technique, which probably we should discuss today, will be the fanning technique to improve the tissue yield, which was described in 2013 by Dr. Shyam Varadarajalu and the group. It showed that once you use a fanning technique where needle is passed from one end to another, making a to and fro movement, then there is a significantly higher, greater first pass yield, thereby reducing the number of passes and overall higher yield, 85 versus 58%. This probably has now been used universally by majority of the sonographer when looking at the pancreatic masses. There are certain other techniques. Instead of dry air suction, should we use a wet suction, or as called as a West technique, where we pre-flush the needle with saline and believe that the water is less compressible as compared to the air and hence applies a more negative suction and can have a more tissue. However, this has not been universally accepted, and very few people are currently using a wet suction technique. There's another modification of the suction technique in which the stylet is moved very slowly, thereby creating a low negative pressure and causing a suctioning of the tissue in these circumstances. Here, the studies which are available show that histologic core obtained with FNB needle while using a capillary technique definitely show an improvement as compared to not using these techniques. While we are talking about the solid lesion, we always fell short of the figures which we get in solid lesion when we are looking at cystic lesions, especially when pancreatic cystic lesions are concerned. So how do we improve the tissue acquisition by different methods in this? One of them has been tried is after complete aspiration of the cyst, repeat puncture and use of FNB in these circumstances improves significantly the tissue yield in these circumstances. Another, biopsy forceps, which can pass through a 19 gauge needle, has been used. However, not many studies are available, but there is a slightly increased risk of pancreatitis with the use of the biopsy needle from the cyst wall. It definitely improves the tissue obtained by using the biopsy needle. As you can see, we can puncture the cyst wall, see if there is any mural nodule, and a targeted biopsy can be picked up from the mural nodule in these circumstances. We can use certain additional studies which are available to improve the tissue outcomes. One of them is tissue elastography, which is stiffer than the healthy tissue and help us to differentiate between a malignant and a non-malignant tissue, and contrast enhanced endosonography, which can tell us the difference between a pseudocyst and a cystic tumor of the pancreas when there is a doubt, or when there are isoechoic secondaries present in the liver or on the liver surface or in the peritoneum, then probably these things can be targeted well. Contrast enhanced EUS can also guide us regarding the sampling of the lymph nodes, when it is which lymph nodes to be targeted, and an ill-defined masses, which can happen fairly commonly in a pancreatic tissue. While using the needle technique, we need to focus on specimen processing also when it comes out. And the most important of that, which has been discussed extensively, used majority of the times mainly in the United States, not as commonly in Europe and Asia, is rapid on-site evaluation or ROSE. Here, air-dried spheres are obtained with discrete stains, and there is an immediate evaluation of sample quality. It gives higher outcomes. However, if we use an FNB needle and use a cell block preparation, then 90 to 95% of the times diagnosis can be achieved, and hence there is very little use of ROSE in these circumstances. So how do we prepare a cell block when we have it? We blow through either in saline or in a special medium. And if we are using saline, we need to send it to the lab for processing immediately, which can be rotated, and cell pellets are fixed for H&E staining. Here we can use this tissue for immunocytochemistry and flow cytometry. As I just said, that we can obtain a near diagnostic accuracy of 90 to 95% when we use FNB needle as compared to FNA needle. Thus, coming to the question, is ROSE really necessary? Not so. If we are using FNB needle and combining it with other techniques like cell block, then we are achieving a very high diagnostic accuracy, which can be compared with ROSE. ROSE increases significantly the cost, and the availability is always an issue. Pathologist has to be available at the same time, and hence, in majority of the circumstances, probably ROSE is not really necessary today. So, what do we gain out of using the FNB needle when we are comparing it to FNA needle? I have already said more tissue, fewer passes, ability to procure sample, do molecular analysis. Yeah. We are not yet ready to abandon FNA because certain areas are superior, as like in distal biliary strictures. So does one size fits all by using an FNA or FNB technique? No. We have lots to choose from. There are certain areas of certain gray areas, but definitely we are in a far superior position than we were in 1992. Thank you very much for your patient listening.
Thank you, Dr. Rajkumar. That was an excellent talk regarding FNA and FNB techniques. We shall move on to the next lecture. I think we will have a discussion at the end of the session. So it is my pleasure to introduce Professor Filiz Akyüz from the Istanbul University. She will deliver her talk on EUS-guided liquid biopsy, the 2021 updates. Over to you, Professor Filiz.
Thank you for this opportunity. And my subject is liquid biopsy updates. I think you can see my screen.
Yes, we can see that.
Okay. We need good quality sample for the diagnosis. In order to obtain sufficient material, it's necessary to use appropriate technique for different lesions. Dr. Kamar clearly demonstrated different techniques, and in fanning technique, after we puncture the lesion, we retract the needle to the tip of the mass and change the position, and we can repeat this procedure at least 3 times. And in multipass technique, after puncturing, we retracted the needle outside the lesion, and then again puncture it, and again we can repeat this system at least 3 times. Generally, we use 20 gauge with stylet vacuum aspiration, and we should move the needle to and fro motion at least 5 to 20 times. Sometimes we can combine these techniques. If the lesion hypervascular, we can use capillary technique or wet suction technique after we saw clot. How to improve our success? Improve our skill, choose right needle, use right technique, and have a good team, especially pathologists. 20 gauge needle we generally prefer. When we need core biopsy, we can prefer ProCore, SharpCore, and the other FNB needles. For cystic lesion, single pass generally advised. For solid or mixed lesion, fanning or multipass, it can be available. After we take a biopsy or aspiration, first we should evaluate macroscopic view of the sample. Sometimes we can decide if it's enough material or not. You can see the enough material in the slide, and sometimes here you see not smooth, so we can decide this material is enough for pathologists. It's better to reach rows, but sometimes it's not available in every case, for every case. In the study, clearly showed that if the macroscopic visible core length is higher than 4 millimeters, this can be an indicator of specimen adequacy and can improve diagnostic value. Diagnosis rate was statistically higher with on-site pathology, but again, it's not available for every center or every case. So we need something different. Liquid-based cytology can reduce the false negative results because it produces better specimen preservation, clear background, high cellularity. And also we can analyze molecular assay by EUS-FNA. In our center, we use CytoReach and SurePad technique for liquid-based cytology, but in different centers, different medium can be used, or different techniques for liquid cytology can be used, like TIMPREP. You see the smear, conventional smear, stained by Giemsa, and adenocarcinoma was diagnosed through PET technique with liquid-based cytology and cell block. Cell block can yield a conclusive diagnosis by immunohistochemistry and molecular assays. Also, in the second step, we can analyze several genetic abnormalities involving KRAS, especially KRAS mutations and the other mutations. In this case, gastrointestinal stromal tumor was diagnosed by liquid-based cytology with cell block immunohistochemistry positivity. And in this case, adenocarcinoma was diagnosed only conventional smear technique from pancreatic mass. And in this case, neuroendocrine tumor was diagnosed by cell block in 60-year-old man. And here, adenocarcinoma was diagnosed through PET technique by liquid biopsy histology. And you see the clear background and high cellularity. And in this rare case, extranodal marginal zone lymphoma was diagnosed, only 20 gauge needle by liquid-based cytology and cell block immunohistochemistry positivity. And here, gastric metastasis of ovarian adenocarcinoma was diagnosed, again, liquid-based cytology with a positive immunohistochemistry. On the other hand, plasmacytoma was diagnosed by just conventional smear in this case. And solid pseudopapillar neoplasm diagnosed by liquid-based cytology in this case. Evaluation of smear, small tissue fragments in cell blocks or small core biopsies if it's possible, often provides sufficient information for correct diagnosis. So we need first to conventional smear and then to put our material in the medium for liquid-based cytology, cell block, if it's possible, for microbiopsies. In the old study, cell block and conventional smear diagnostic rate is higher than the liquid-based cytology. And also, this study showed, liquid-based cytology showed a lower diagnostic rate in pancreatic EUS-FNA. On the other hand, recent studies showed even the learning curve for EUS-FNA, liquid-based cytology diagnostic rate is higher, especially if the lesion site is higher than 2 centimeters, this diagnostic rate will be higher. And in the study showed liquid-based cytology combination with conventional smear improves the diagnostic efficacy of our FNA technique and compared to liquid-based cytology alone. In this meta-analysis also clearly showed that liquid-based cytologic diagnostic accuracy for malignancy is higher than conventional smear and also lower rate of artifact. And this study showed higher agreement for cell block and provided higher diagnostic accuracy and comparable inter-observer agreement than smears. So they concluded that LBC may be alternative to conventional smear, especially if we cannot reach the rows. In this retrospective study also showed that doing more than 3 passes is associated with higher sensitivity when using smear, conventional smear, and pancreatic location of lesions, solid lesions, 20 gauge needle, and more than 3 passes are associated with higher sensitivity when using LBC. And also this study confirmed that combination of smear with LBC improved our diagnostic efficacy. If only one method can be applied due to limitation, LBC is a better choice. This is a prospective randomized non-inferiority study, and also this study showed liquid-based cytologic diagnostic rate is higher than conventional smear, but not statistically significant. On the other hand, if we compare cytomorphologic features of these two techniques, in liquid-based cytology, we have more clean background, no blood, no mucin, and high cellularity. 19 gauge and 22 gauge needle has similar diagnostic efficacy. And also in this meta-analysis compared the subtypes of techniques for liquid-based cytology, and SurePET precipitation technique has higher diagnostic value for malign lesion, and diagnostic accuracy rate is higher in precipitation technique, SurePET technique. We have some advantage and disadvantage for both techniques, conventional smear and liquid-based cytology. In the absence of rows, precipitation-based liquid-based cytology should be preferred over conventional smear technique in EUS-guided sampling of pancreatic lesions. Also, in this recent published meta-analysis showed combination of these techniques, conventional smear plus liquid-based cytology, improve our diagnostic rate. KRAS mutation analysis using residual LBC specimen improves the diagnostic accuracy of FNA. For pancreatic cystic lesion, also molecular analysis for KRAS and GNS mutations has high sensitivity and specificity with significantly improved diagnostic accuracy for diagnosis of IPMN and mucinous lesion when compared with CIA alone. In this case, you see the group of epithelium showing a drunken honeycomb pattern, but we are not so lucky in every case. For pancreatic cystic fluid, we should analyze molecular analyzation and biochemical analyze, and then to put our sample in liquid-based medium, so we can analyze the cytology. How about guidelines recommend? FNA and FNB needles equally recommended. When on-site cytologic evaluation is unavailable, ESKE suggests performance 3 to 4 needle pass, and ESKE also suggests combination of these histologic preparations, cell block, liquid-based cytology, and conventional smear. As a summary, many factors affect the tissue quality. ROSE is very effective for higher diagnostic rate, but it's not available at all hospital or at all times. LBC might eliminate the need for ROSE and result in higher quality slides and similar diagnostic yield compared with conventional smear. However, diagnostic capability of EUS-FNA can increase the combination of these techniques. Liquid biopsy and molecular analysis should also be evaluated in cystic lesions. Thank you very much for your patience.
Wow. Thank you very much, Professor Phyllis, for your nice talk. We have learned from you that if we combine both techniques together, perhaps we get more yield for helping of our patients with lesions. So I'd like to thank Professor Phyllis very much. And I'd like to introduce the third speaker in the topic of the EUS staging for pancreatic cancer by my friend who is a famous endoscopist in the world, Professor Nagai from Japan. Professor Nagai now he is working at the Department of Endoscopy and Endoscopic Surgery at the Graduate School of Medicine, the University of Tokyo. So I like to welcome Professor Nagai. Nice to meet you again, Nagai.
Yeah, nice to see you again.
Yeah.
Thank you for introduction, Pradam Chai. So I will start.
The upward arrow.
Yeah.
All right, good. We can see it.
Okay. So I will start my presentation. So I will talk about EUS staging of pancreatic cancer. So as we all know, the incidence and the mortality of pancreatic cancer is increasing year by year. There's some role of EUS in pancreatic cancer: detection and staging and tissue acquisition with and or without genome profiling. And they maybe in the future, there may be a role for fine needle injection or ablation of pancreatic cancer. And we have to think about we are in the era of neoadjuvant chemo or chemoradiation therapy for pancreatic cancer. So first, I will talk about detection of pancreatic mass. When we compare EUS with CT, ultrasound, MRI, the sensitivity of EUS is higher than CT or ultrasound or MRI. It's reported as high as 94%. And sometimes we can detect a small lesion which are missed by CT scan. In this meta-analysis, EUS detected a mass in 70% of indeterminate multi-detector CT scan. The lesion size was 21 millimeter. So if we perform EUS, we can detect like a 1 or 2 cm lesion which are not detected by CT scan. So when there is a clinical suspicion of pancreatic cancer, we have to perform EUS even after negative CT scan. When we talk about early pancreatic cancer, we have to think about this better survival. So in this Japanese multi-center study of 200 early pancreatic cancer, about 50 cases of stage 0 carcinoma in situ and 150 stage 1 pancreatic cancer. When we look at the survival curve, it's ideal to detect pancreatic cancer less than 1 cm, which is very difficult for us. In this study, they compared image finding of EUS and CT, MRI, or ultrasound. And the EUS can detect a very small lesion. It's about 76% compared to 50% on CT scan when we combine the stage 0 and the stage 1 pancreatic cancer. But if it's stage 0 pancreatic cancer, EUS can detect only 24% and CT only 10%. But when we carefully image the pancreas, we can detect dilation of pancreatic duct or stenosis. And if we find these findings, we can perform ERCP or other invasive modalities to rule out cancer. So we have to focus on the tumor, but also pancreatic duct. I will go back to the workup for pancreatic cancer. This is from the NCCN guidelines. When there's a suspicion of pancreatic cancer, we often perform CT to evaluate pancreas and also check liver mets. And if there's a mets, we can perform EUS or CT-guided biopsy to confirm malignancy. And if there is no mets, then we can perform EUS for local involvement, or we can also perform MRI to detect small liver lesion. This is a diagnostic aid of EUS for local involvement of pancreatic cancer. As you can see, we can evaluate resectability of pancreatic cancer as high as 90% of sensitivity and 86% of specificity when we perform EUS. This is a comparison of EUS and the CT scan. As you can see, EUS is better than CT for local staging. And after EUS, the patient will have a better survival because of the better staging. The patient can have a appropriate management of pancreatic cancer if we perform EUS. However, recently, EUS is also utilized for tissue acquisition before surgery. More and more patients have a EUS-FNA in the case of surgically detectable pancreatic cancer. This is a sensitivity of EUS-FNA for pancreatic solid lesion. It's about 90%, so it's very high, and also specificity is over 95%. And we can also evaluate vascular invasion by EUS imaging and also EUS-guided tissue acquisition. This is a report of the EUS detection of vascular imaging. You can see the mass around the confluence of portal vein. So we can evaluate the vascular invasion by EUS. And in this report, EUS is better than CT for vascular invasion evaluation. And if we find these kind of vascular invasion like this on CT scan, we can also perform FNA because EUS has a very good spatial resolution. We can avoid puncturing the vessels, and we can target these tiny soft tissue around the vessels. In this Korean study, they reported EUS-FNA can diagnose about 65% of the vascular cuff, this soft tissue around the vascular region. And they recommend lows or repeated FNA to have a high diagnostic yield. And we can also perform non-regional lymph node like a para-aorta lymph node when we perform EUS. In this Japanese study, they compared EUS-FNA with a PET-CT scan. And the EUS-FNA was better than PET-CT to diagnose non-regional para-aortic lymph nodes. When there's a positive non-regional para-aortic lymph nodes, then we can avoid unnecessary laparotomy. In this report, they found non-regional para-aortic lymph node in 8 out of 52 patients. So it can avoid unnecessary surgery. And recently, there are some reports using a contrast-enhanced EUS to detect a very small, tiny lesion in the left lobe of the liver. On the image of EUS, this is a B mode. It's very difficult to find a liver lesion, but after contrast enhancement, Kuppa phase imaging, we can clearly detect the small lesion in the liver, and we can also perform a FNA to confirm the malignancy in this tiny lesion. So by performing the EUS in pancreatic cancer, we can avoid unnecessary surgery because we can detect also ascites or peritoneal carcinomatosis. In this study, they found 30% of carcinomatosis in patients with ascites. And even in patients without ascites, they diagnosed 4% of carcinomatosis by EUS. In those cases, we can also avoid unnecessary surgery. So by performing EUS to detect a small liver lesion or vascular invasion or to rule out ascites or carcinomatosis, EUS can detect undetectable disease in 14% after negative CT scan. So we should focus on these strategy changing features like a small liver lesion when we perform EUS. And as I talked in the first, we are in the era of neoadjuvant treatment because when we diagnose resectable pancreatic cancer on CT scan, there are 25% of undetectable disease at laparotomy. And then after resection, we have to give adjuvant chemotherapy. But in 20%, the patient cannot tolerate adjuvant chemotherapy because of the invasive pancreatic surgery. So the patient in this 25% and 20% of patients, the patient cannot have an ideal management of pancreatic cancer. So we are moving forward to neoadjuvant treatment. When we give chemotherapy before surgical resection, the patient can tolerate chemotherapy very well, and also we can avoid unnecessary surgery when there's early disease progression. This is also from NCCN guideline. We used to evaluate vascular invasion by yes or no, but now we have 3 categories: resectable, borderline resectable, and locally advanced disease. And now we have to evaluate the degree of vascular invasion. It's lower than 108 degrees for borderline resectable disease. And if it's over 180 degrees, it's locally advanced unresectable disease. So we have to evaluate these degrees, but on EUS, it's very difficult. So I think CT is better than EUS to evaluate this degree of vascular invasion. So in borderline resectable disease, we are giving a neoadjuvant chemotherapy before surgery. And also in patients with resectable pancreatic cancer, in Japan, we have two options, upfront surgery and neoadjuvant chemotherapy. We are tending to neoadjuvant chemotherapy even in the resectable pancreatic cancer to have a better survival. And we also focus on not only the anatomy, vascular invasion. So when the patient has a high CA99 level or poor performance status, we have to avoid upfront surgery because in those patients, the prognosis is not so good after upfront surgery. We are giving a chemotherapy in this resectable on
Yuzuki,
CT scan.
sorry, Yuzuki, it's Marc Barthé. We
Your screen is
need to share your screen
your
because we
slides
have
are not visible.
no more your presentation.
Really? I will do it
Yeah,
again.
really. Can you share your screen again,
Yeah, I will do it.
please? Because we do not want to lose your slides because it's very interesting.
Yeah. But just a few slides, no worry.
Huh.
Yes.
Yes.
Perfect. Now.
Can you see it?
Yeah.
Okay.
Yes, we can see now.
So this is a classification of borderline pancreatic cancer. As I told you, there's an anatomical borderline resectable pancreatic cancer, but if the patient has a high CA99 level or poor performance status, we also give a chemotherapy, neoadjuvant chemotherapy, to get a better prognosis. So this is our strategy. If the patient has a resectable pancreatic cancer, the patient may have upfront surgery, but we are tending to chemotherapy or chemoradiation therapy in resectable or borderline resectable or locally advanced pancreatic cancer. So now it's not a big issue to evaluate the local staging by EUS. So we have to focus on the distant region like liver mets or carcinomatosis or such kind of region. So the role of EUS is changing from staging to FNA. But we have to be very careful because there's a report of tumor seeding after EUS-FNA, like a body and tail of the lesion. So this is a Japanese multi-center study. They reported needle tract seeding by preoperative EUS-FNA in 3.4%. So we have to be very careful to check CT scan after resection of the gastric wall like this lesion. So when there's these suspicious lesion, we have to check on endoscopy and resect these tumor seeding. And now we are in the era of genome profiling in the metastatic pancreatic cancer. In this NCCN guideline, they recommend genome profiling. And we are using a FNB needle to get more specimen. And there's some randomized control trial. This is the latest RCT from the Baradaraju group. They compared 4 needles, and they reported third generation like Acquire or Shako needle is better than the other needle. And they recommend slope or no suction for better cellularity. And this is a comparison of EUS-FNA and the FNB needle for genome profiling. In this report, they use a Foundation 1 commercially available genome profiling. And if when they use a 22 or 19 gauge FNB Charcot needle, they can perform foundation 1 screening in 78%. So when we think about genome profiling, we have to choose this FNB needle, and we should choose a 22 or 19 gauge needle. So this is my last slide. For detection of the pancreatic mass, EUS has similar or better diagnostic lead compared to CT scan. And I have to emphasize we are in the era of neoadjuvant treatment. The role of local EUS staging is decreasing, but EUS can diagnose non-regional lymph node or small occult liver disease or peritoneal mets. So we have to focus on these EUS evaluation, and EUS-guided tissue acquisition plays an important role more than ever. Thank you for your kind attention.
Thank you, Professor Nakai. That was an exhaustive talk on pancreatic cancer staging. Thank you for that kind lecture.
Thank you.
We now move to Professor Marc Barthet from France. He is going to show us a case, which is a recording of an interesting case that has been performed. And over to you, Professor Barthet, for that case.
The first case is about a woman. This patient, we found a pancreatic lesion incidentally discovered at CT scan, workup for discal hernia. The EUS exploration, we found a cystic lesion, 19 millimeter diameter, with 6 millimeter wall thickening. After injection of Sonoview, we found hyper-enhanced. The 22 gauges FNB, the histology found net G1.
So welcome to everybody. So we are very pleased to share with you some cases of radiofrequency ablation for different pancreatic tumors. So I'm very proud to show you my team. So Olivier is my nurse of anesthesiology, and Corinne and Manu are my nurse for endoscopy. And of course, Mohamed Gasmi is my co-worker and is very involved in the field of treating pancreatic tumor with radiofrequency ablation. So we are starting with the first case. And as you saw, it's a patient, a young lady, with a pancreatic tumor, a cystic pancreatic tumor, which finally is endocrine tumor. You know, it's cystic tumor are about 10% of endocrine pancreatic tumor. And so now we are going to check the pancreas. The tumor was located in the body or in the body? Okay, so we are looking through the gastric wall, and now we are at the level of the superior mesenteric vein. Okay, you see it. And you see also the head of the pancreas. Okay, and now this is the portal vein. Okay, going to the liver. And now I will turn my scope to follow the splenic vein, and the splenic vein is just there. This is the neck of the pancreas. And now you saw the lesion. You see clearly the lesion is just there. Okay, located in the body of the pancreas. Okay, just there. So we are going to measure and to do fine flow to see if we have any vascular enhancement with fine flow. Yes, you see on the solid part of the tumor. Okay. Okay, and now I will fix the image, and we will measure the diameter of the lesion, which is about 17 millimeter. Okay. Okay, so now we are going to prepare Sonoview to do contrast enhancement, and after we will do the radiofrequency ablation. And so maybe you can ask why we are doing contrast enhancement, but because this is a target for the radiofrequency ablation efficacy. So we do contrast enhancement before and after we check with the Sonoview again.
after radiofrequency ablation to see if we have no more enhancement. This is a very important criteria for efficacy. We restart again. So my nurse is just injecting the Sonoview. And you see the mechanical index setup is 0.12. And now we are waiting for the contrast enhancement. Okay, you see clearly, Mohamed is showing you on the solid part of the tumor, you see the contrast enhancement, typical of neuroendocrine tumor. Okay, and you see also the wall with a huge contrast enhancement of the wall of the lesion. So clearly, it's a cystic neuroendocrine tumor, and I already told you that this is about 10% of the neuroendocrine pancreatic tumor. Okay, so now we are just looking to the washout. We have until now we have no washouts. Yes, washout is starting now. And you see the solid part, we have no more contrast enhancement. So we did the contrast enhancement. You see a huge contrast enhancement at the arterial phase. And now you see the cystic lesion with the thickness of the wall and the solid part. And you can see also the Wirsung duct, which is closed to the lesion. But before treating this lesion, because this is a cystic lesion, we have to suck the fluid content, because if not, you decrease the efficacy of radiofrequency ablation, and also you increase the application of radiofrequency, and you have a high risk of burning adjacent structures, like the Wirsung duct, like spleen vein and everything. So the first step will be, as for IPMN, to suck the fluid content. So I'm just using, if you see, the 19 gauge needle. So I'm pushing out the sheath, okay? The sheath is just there, not too much. And now I am going to go inside the lesion with the needle. Okay, and now we are going to suck the fluid content. And so the nurse, yes, you can retrieve the stylet. And now the girl, of course you are a girl, but the nurse, sorry, is going to suck, but is going to suck manually. Because when you have no more liquid, you have to stop the suction. As my nurse is sucking the fluid content, stop. You see, we have this very thin layer now, and now we can stop. Okay, okay, and you see the thick wall of the endocrine tumor, which was not visible before sucking the fluid content. Okay, perfect. So now we are going to stop the suction. The suction is stopped because mine is not sucking anymore. And now you see, I'm just retrieving the sucking needle. And we will exchange with the RFA needle. So now we are going to do radiofrequency ablation, EUS-guided. So before starting, we have some prophylaxis to do. The first one is NSAID, like for prevention of pancreatitis following USCP. And the second one is antibiotic prophylaxis to avoid superinfection of the necrosis induced by the radiofrequency ablation. So this is done by my nurse. And the second point is I just want to show you the needle we are going to use. This is a 19 gauge needle with double setting, like for any FNA or FNB. You see the setting here for the output of the sheath. And here you have the ring for the setting of the output of the needle out of the sheath. Okay? So this is a 19 gauge needle. And you see this is the sheath for freezing the needle, because this is a freezing needle, and this is very important to decrease the side effects and also to increase the efficacy. So now I'm showing you the generator. So you have on the left part of the image the generator with a setting of 50 watts, and here you have the window for impedance, because we are following the window, because when you reach 100 ohms, you have to stop the radiofrequency application. And the second machine is a freezing pump, just injecting frozen water inside to freeze the needle and to, as I told you, to avoid any side effects and to increase the efficacy. So now we are going to start, because we have the prophylaxis, antibiotic prophylaxis, NSAID prophylaxis. We have the setting of the generator. The freezing pump is okay. And now we have also the needle. And so we can start the radiofrequency application. And as you see, now we have the lesion, which is just there. Okay? And I'm going to treat. And we have nearly just a very thin layer of fluid inside. And we are going to treat with the needle. Okay, so I have to inject. And maybe we are going to use 2 applications. So I'm just putting out the sheath. Okay, now you see the sheath. Okay, so I think we have to use probably two shots. Mohamed, I don't know if you agree with me. So this is the first implantation on the left part. Okay, and now we are just inside. So we are going to start the radiofrequency application. So you can start now. Okay, you see the Virson duct is not so far, so we have to take care.
The white bubbles.
Okay, okay, stop. Now we have to stop because you see the white bubbles flowing out the lesion. And also at the same time, we had the impedance. We was showing 130 watts. So we have to stop and we have to do a second application. Okay?
In this part.
Okay, yes, on the right part of the lesion. Okay, so now. So I have to see clearly the tip. Okay, now the tip is just there. Okay. Okay, I see it's a little bit deep, so I pull it back gently, and now I'm inside. Okay. Okay, and now we can start.
Very nice.
Okay, start. Okay,
stop.
Stop now. Okay, because the white bubbles were a little bit flowing out, and also because we have we reached 400 watts, so it's very much. So we have to stop. Okay. So now I just check if we have to do another injection, another application. Maybe you see just in this part, but we have to be very careful because we are very close to the Virson duct. So the patient is breathing very hard. So it's a little bit difficult. Okay, so you see the needle is, no, don't start. Huh? The needle is close to the Virson duct, so I have to pull back. Okay, just applying. Okay, and now I'm in the good position. Okay, now we can start. Okay, so we start. So we do 3 shots. Okay. Okay, and now stop.
Stop.
Because you see, I'm very close to the Virson duct, and I don't want to do any injury of the Virson duct because we have one side effect in our prospective series of 30 patients, and this was due to a Virson duct close from 2 millimeters from the target. Okay, so now I put back the needle. Okay, so with fine Doppler we have no vascularization. Okay, perfect. So I retrieve completely the needle, and now we are going to check with Sonoview if we have really complete disappearance of the vascularization of the lesion. And you see, maybe we have a small hematoma. just between the pancreatic gland and the gastric wall. Okay, you see, Mohamed is showing you. So now we show you the Doppler and the fine Doppler assessment of the lesion. So now you see we have no more vascularization of the lesion. Okay, so it seems to be efficient, but we have to control, of course, with contrast enhancement with the Sonoview. And also we are going to show you about the hematoma. And you see we have a vessel crossing the small hematoma between the pancreatic gland and the gastric wall. You see it very clearly. You see it? Okay. But we have no blush, outside blush of this vessel crossing the hematoma. So if you have any bleeding with blush due to a vessel injury, so you can use injection of cyanoacrylate and lipiodol inside the vessel to stop the bleeding. So don't be afraid. You keep your EUS cup. You use a 19-gauge needle and you inject a mixture of 1 milliliter of cyanoacrylate and 1 milliliter of lipiodol, and you inject it in your 19-gauge needle, and everything is finished. Okay. So now we are going to use the Sonoview assessment. So now the nurse injects the Sonoview cautiously. Okay. And now we are waiting for vascularization of the lesion.
There is no vascularization.
No more vascularization. Yes. Looking to the, you see, looking to the wall and seconds. Looking to the solid component. Yes. And you see some white areas, but this is the white bubbles due to the injection. But you see no more vascularization of the cyst wall and of the solid component. Okay, so we have a very good target for efficiency. So normally, with this kind of treatment, after looking to the assessment of Sonoview, if you have no more injection, you have an efficacy of 85% of resolution of the neuroendocrine tumor, even if you follow the patient until 4 years. So we did that in our last series with a long-term follow-up. And so you see you can be efficient. And you see this is very impressive because you have no more vascularization, only the white bubble. And also, you see, I just want to see if you have any bleeding in the hematoma, but we have no more bleeding in the hematoma, which is very stable. So no problem. You do just antibiotic prophylaxis and everything is okay. So this case is finished. So the message, take-home message is, first, don't forget the prophylaxis, antibiotic and NSAID. Secondly, assess the neuroendocrine tumor with a contrast enhancement. Do the radiofrequency application with no more than 3 shots. And finally, you assess again the lesion by using again contrast enhancement, and you just check you have no more enhancement. So thank you, and we will prepare the second case. Thank you to everyone.
Oh, very nice demonstration of the IFA to the net, right? Yeah.
Thank you.
Yeah.
Thank you. Now I think it's time for opening the discussion, if you agree. The discussion with all the presenters.
Professor Pathe, are we having a second case or should we begin the...
No. We have no second case because I have not enough time to show you cystic treatment of IPMN with some features. So I just select this case because we have not enough time. So I think if you are the moderator, and Kit.
I just had one question for Professor Phyllis. Because I had a doubt on the lecture which she had. Is the liquid biopsy synonymous with biopsy in liquid medium? Because my understanding of liquid biopsy is a liquid collected to look for DNA material of the tumor cells, which give us an additional source of diagnosis, like puncturing a portal vein for assessment of pancreatic carcinoma.
Yes, in mostly.
I was confused after a lecture whether liquid biopsy is same as biopsy in a liquid medium.
Yes, Dr. Rajkumar. Before this lecture, I also confused with this terminologic items, but in literature, some articles use the synonym liquid-based cytology and liquid biopsy. So when you take a FNA or FNB, it doesn't matter. First, you should put in medium. Then, if you need it or if it's possible, it's better to analyze GNS mutation, KRAS mutation, and the others. So some literature use this synonym, some literature use different terms, but I combined both of these terminology.
Professor Padamchai and Professor Batet, any opinion on this?
You want to answer, Padamchai?
No, please, Mark, if you can, because I cannot hear clearly. So please, yeah.
It's the same for me. What you can repeat your question, Rajkumar, please?
Sir, I was under the impression liquid biopsies are the biopsies collected for liquid medium to assess the circulating tumor DNA or particles like exosomes to diagnose a malignancy which is beyond the site of origin. While what we have looked into is a tissue biopsy taken in a liquid medium.
I'm not doing at all liquid biopsy as a current practice. I have a control study actually to try to assess proteomic profiles of adenocarcinoma. But it's for research. It's not for clinical assessment. But I think really we have a real hope for this patient because not only for the diagnosis of adenocarcinoma, but also for the profile, the sensitivity to chemotherapy or to radiotherapy or to surgery. So I think this probably is not really for the diagnosis, except in doubtful cases, but probably for the management or the future management of this patient, it could be very useful. But for me, actually, it's mainly for research.
And also, it's possible to it's also possible to analyze cell-free DNA in this medium or portal vein sampling. Also, we can analyze cell-free DNA or the other mutations. But in also literature, these terminology, it's a bit mixing.
Yes, I think Dr. Rajkumar, what you're saying is that in literature there are studies which mention liquid biopsy as portal vein sampling for assessing cell-free DNA for basically early detection of pancreatic malignancy and prognostication. So there are a couple of reports which do specify portal vein sampling as liquid biopsy. But I think, as Dr. Professor Felice said, this nomenclature can be, I think, mixed. So it could mean both.
Yeah, actually, oncologists use liquid biopsies fairly often, and any liquid sample collected which is sent for the there are 2 or 3 specific things which they use. One is an exosomes. These are vesicles which are liberated from the tumor cells, either circulating tumor cells as a whole or circulating broken DNA from these cells, which help us to analyze both the early cancer as well as the spread of the cancers. And this could be any liquid tissue taken from anywhere in the body. And for us, as an endosonographer, when we normally pick up for pancreatic cancer from portal vein sampling, which as Professor Bhatt said, that it is still in experimental stages rather than in daily clinical use.
Okay. I think we have some questions from audience. So let me start the first question with Professor Watwa. Because sometimes it's difficult to do the FNA or FNB from the target lesions because of intervening vessel. So at this time, we also do the liquid biopsy from the portal vein, hepatic vein sometimes. So is it possible to pass the needle across the intervening vessel to the target lesions? Maybe we start with Professor Watwa.
Thank you, sir. Thank you for this question. Yes, however, this situation is not very common in an expert endosonographer's view. We will be able to find the window in majority of the circumstances. If it is absolutely not able to find the windows and patient is not on anticoagulants and does not have a bleeding tendency, then a 25G needle can be safely used to obtain the sample in these circumstances.
So,
Professor Wadhwa, would you prefer using any particular needle for such a situation, and would you prefer to have rows on site so that you would not have to do multiple passes? And
Yeah, of course, we will prefer to have a Francine type of needle, and if we are using a technique which will give us if rose is available, better. Not available, still acceptable.
right.
I'm sure not many of us in India or probably in Asia use rose under any circumstances.
True.
So we tend to do these biopsies even without rose.
Right.
Okay, you have next question?
Yes.
So,
Okay, go ahead, Dr. Pradhan.
okay, so the next question maybe for Professor Nagai. I mean, any difference or chance of seeding when you perform transgastric FNB or FNA from solid versus cystic lesion of the pancreas?
Right. So yeah, it's a very difficult question, but in the question he or she asked, transduodenal pancreas is better, but in the region of the body or tail, we have to go transgastric, and in this region, there is a chance of tumor seeding because the stomach remains after surgical resection, and in those resectable lesions, we prefer to reduce the number of the puncture. So we ask those in this kind of situation. I'm not sure FNA or FNB makes a difference, but we often see the Doppler signal after using FNB needle through the needle tract. So maybe there's a high risk of tumor seeding when we use a FNB needle, but I don't have exact data, so we have to see.
Yeah.
And there's a question in continuity. Would you perform an FNA or FNB if it's an operable pancreatic mass?
Yes. So if the patient has will have a upfront surgery because the lesion is very small, and if the CT shows a typical finding of pancreatic cancer, then we may not perform FNA. But recently, we give neoadjuvant chemotherapy more and more. So in those kind of patients, we have to have a pathological diagnosis before chemotherapy. So we are doing FNA in those potentially resectable pancreatic cancer.
Okay.
May I ask a question to Professor Nakai? Yuzuki, I have a question about IPMN. I know you published a lot about IPMN, and sometimes we have some associated area of panning lesions, and sometimes we have adenocarcinoma arising from this area and far from the IPMN targeted lesions. It's about, I think, about 5 to 6% of the cases. How do you target these lesions? And have you a special way to find these lesions? And how do you biopsy these lesions? With FNA, with FNB, what are you doing?
So do you mean the lesion away from the
Yes,
cystic
the
lesion?
lesion away from IPMN, which are called PANI lesions.
Yeah. So in those panning lesion, basically it's a concept of micro lesion.
Yeah.
So it's difficult to get a pathological diagnosis by FNA or FNB. When we see a mass on EUS in the panning lesion, it's basically a fibrosis or inflammation around the tiny lesion. So we cannot get a pathological diagnosis. So if there is a suspicion of pancreatic cancer, very small pancreatic cancer, we prefer ERCP and put a nasal pancreatic tube to get cytology from pancreatic juice, because FNA cannot get a accurate diagnosis.
Okay.
But I think it's only in Japan.
Okay.
Yeah.
So I have
I
one
do
here.
in some case FNA, and I got some diagnosis of dysplasia, because usually they are small areas, hypoechoic areas, not well delimited, and with some microcystic lesion inside. And I target the needle inside, usually FNA, and I have some cases with dysplasia. And the final surgical pathological examination was Palin 3. Maybe we can combine USCP, because it's ductal lesions, and EUS-FNA.
Yeah.
Yeah, we also perform FNA when we see a mass on EUS, but if it's negative, then we will perform ERCP.
Okay.
Okay. Professor Mark, may I have a question for you?
Yeah.
Okay. So I like your presentation very much, that you do the RFA on the neuroendocrine neoplasm of the pancreas. But for the RFA probe, they have some length, and they have some area of active probe. So what is the smallest target lesion that you can perform with RFA? I mean, because if the lesion is big, then the RFA probe will not burn out outside the lesion, but in small size of lesions. Yeah.
Yes. So your question is about the smallest target you can treat with EUS RFA. Huh?
Yes.
Okay. In fact, it's not a technical problem. It's mainly a question of indication. Because for a neuroendocrine tumor, for instance, we are not sure we have to treat lesion less than 10 millimeter. Because in lesion less than 10 millimeter, usually it's Wool's classification 1, grade 1. So you do not need any treatment. You follow the patient. The problem is mainly between 1 to 2 centimeter. So these patients are usually G1, but can be G2 in about 10 to 20% of the case. And so you have to treat these patients. So making surgery for these patients is maybe too hard for the patients, and you can treat them efficiently with RFA if they are G1 tumor. And we have actually, with 4 years follow-up, 85% of complete disappearance of the lesions. So it's very interesting. More than 2 centimeters is for surgery. Less than 1 centimeter, normally you have nothing to do, except in genetic disease, like in NEM1. This patient with multiple neuroendocrine net tumor in the pancreas. I'm treating lesions 1 to 2 centimeter, and also lesion less than 1 centimeter. because after I follow the patients, and I think it's better if you can treat all the pancreatic gland, avoiding any extensive surgery.
Yeah, thank you. Yeah, and also, I mean, I have read one of your paper, which is very interesting. You also did the IFA on the pancreatic, cystic pancreatic neoplasm. So, to your experience, any difference in terms of technique using IFA to burn solid pancreatic lesion like neuroendocrine neoplasm or cystic neoplasm of the pancreas?
It's a little bit different because the main difference is you have to suck the main part of the fluid content, because if not, you apply too much radiofrequency current and you have a risk of burning surrounding structure. So this is the main difference. But as you saw in my video, you let in place a thin layer of liquid, not to lose your target, because if you suck completely side branch IPMN, you can lose those targets. So the main difference is you have to suck the main part of the fluid content. The second difference is not a technical difference, but a result difference, because we are not so efficient with IPMN than with a neuroendocrine tumor. The resolution of the cystic lesion is about 2/3 of the cases only, compared to 85%. But in all the cases where we performed RFA for worrisome features or mural nodules for IPMN, we had a complete disappearance of the mural nodules without any recurrence with 4 years follow-up. So this is interesting, because in this patient, you ask for the surgeon to do pancreatic resection. Okay, if it is in the body of the tail, the risk is not so high. But if you are at the level of the head of the pancreas, you can have some death of the patient, about 5 to 10%. So if you have 5 to 10% of people dying for high-grade dysplasia or superficial carcinoma, it's terrible. So actually, we are working with our surgeon for new algorithm. So we start in case only of side branch IPMN, and not of the main pancreatic duct, of course. Main pancreatic duct is for surgery. And we start with radiofrequency ablation, and we follow the patient. If we are not confident with the results, we send the patient to the surgeon. If we are okay with the results, we follow the patient.
Someone's asking, what is the incidence of pancreatitis in your CTs when you've done RFA?
If you do NSAID prophylaxis like for USCP, it was less than 3% of the cases in our prospective study.
You use NSAID enemas or oral NSAIDs in these situations?
I use for USCP rectal diclofenac.
In enema form or orally?
Sorry?
Is it a suppository or you give it an oral tablet?
No, I give it for all the patients. I give it for all the patients. This is a systematic prophylaxis for all the patients. Okay. The question usually is, you saw on the image, the Versong duct was close to the lesion, to the net tumor. And I have often a question, have we to treat, to do a prophylactic pancreatic stenting to avoid any pancreatic ductal injury? It's a discussion, because in our series we had 3% of pancreatic ductal injury, which was a stenosis, and we had to treat this patient with pancreatic stenting, and everything was solved after. But if you do prophylactic stenting for all the patients, the complication rate is more than 5% of the cases. So it's a very difficult choice. You have to discuss with the patient, to discuss with the radiologist, with the surgeon. And usually we prefer to follow the patient, except if the Wirsung duct is less than 2 millimeters far from the lesion.
Okay. All right. Okay. There is probably time for another question. Maybe I have question for Professor Nakai. Look, you talk that probably at this time even operable pancreatic cancer likely that we give the neoadjuvant chemotherapy. So that's why we need the tissue diagnosis before that. So then, and most of the time, the tumor at that time will be very small, right? And would that be considered more difficult to get enough tissue or any special technique that you use every day to get adequate tissue from such a small pancreatic lesions and operable? Because you're also concerned about the seeding as well, so you try to minimize number of the FNB, right? Yes.
Right. Yeah, like so. Yeah, I don't have a special technique, but I use a 22 gauge FNB Francine needle because it can get more tissue. And if it's available, we ask cytologist to perform loads to have a confidence to get a specimen. But I don't have any special other techniques.
All right, and Dr. Professor, what about Professor Phyllis? You want to answer this question as well?
Sorry, I couldn't hear the question clearly. Can you repeat it?
In a small operable pancreatic mass, sometimes surgeons need tissue diagnosis, but because the lesion is very small, it is difficult to get the tissue from such a small lesions. Any special technique to get the tissue?
Okay. Generally, in our routine practice, we didn't prefer to take a biopsy if all radiologic images and the clinics refers to the patients has pancreatic cancer. So we referred these patients directly to surgeon. Yes, sometimes surgeons want to confirm the diagnosis, even all these findings represents the carcinoma or pancreatic cancer. But there is no specific techniques for these lesions. Our standard similar techniques maybe improve our diagnosis rate, FNA, FNB, or etc., even small lesions. If first time will be negative, so we don't insist, we send these patients to the surgeon.
Okay, all right, thank you. Anything else on to this, Professor Watwa?
No, I don't have anything specific, as Professor Nakai has already said that. In such situations, choose the equipment which is likely to give you the best result. And that probably in the today's days is a Francine needle. If it is deep in the second part of the duodenum, I'll prefer a 25G. But if I'm doing a biopsy from first part of the duodenum or from the stomach, then 22G might as well be the thing. I don't have any specific way to increase the tissue except for what we have discussed about.
All right, thank you. I think it's time, Ankit, you want to say thanks to all our speakers?
Yes, this has been a wonderful session. I would like to thank each and every speaker, Professor Wadhwa, Professor Feliz, and Professor Nakai for their excellent talks, as well as Professor Pathe for that excellent demonstration of EUS-guided RFA for cystic neuroendocrine tumor. Thank you all.
Yeah, we will have a break for 10 minutes and we come back in the next 10 minutes for session number 3.
Session number 3 at 3:40 p.m.
Yes.
Thank you, sir. Thank you all of you.
Thank you to all of you. Thank you. It was very nice. Nice session. Thank you.